Welcome to today's class. Today's class is going to be on basics of refractive surgery. Brief outline of what we are going to cover today. So we are going to cover a bit of history of refractive surgery, classification of refractive surgery, how the laser and tissue interactions occur. Then we are going to learn something about excimer laser, microkeratome, and femtosecond laser, how they have evolved over time and where we are at right now. Then we are going to discuss a bit about the basic procedures. And finally, we'll discuss a bit about upcoming technologies. So Jose Ignacio Barraker is known as the father of refractive surgery. He's been credited with making the first microkeratome and writing the first few textbooks on refractive surgery. So he has done sentimental work on refractive surgery. So coming to the history of refractive surgery, in 1939, Tsutomu Sato used radial keratotomy to treat myopia. In 1953, the first phakic IOL was introduced. In 1964, the father of refractive surgery, which is Dr. Barakar, described keratomiliosis. 1975 saw the onset of thermal keratoplasty. In 1988, the first PRK was performed. In 1990, Dr. Palikaris described LASIK. In 1995, PRK received FDA approval. In 1999, LASIK received FDA approval. Then came the femtosecond laser, which was introduced in 2001. ICL received FDA approval in 2005. In 2007, SMILE was described for the first time by Dr. Secundo. And in 2016, SMILE received FDA approval.
So, Pranav, you said that phakic lenses were described in 1953, is it?
Yes, sir. Phakic IOL, sir. Yes.
Are you sure? In which year did IOLs first started to be used?
IOLs, I'm not sure, sir.
I thought around that time itself, in the 40s or late 40s or something, they first started, describing the intraocular lens itself, the Ridley's, Harold
Yes,
Ridley.
sir. Glass lenses.
Somewhere in that, right?
Yes,
Yeah. So,
sir.
are you sure this is not this is a phakic lens and not intraocular lens?
Yes, sir. Sure, sir.
Okay. So what kind, maybe later on after class is over, maybe you can research that what kind of phakic lens was, described by whom in 1953 and how it was different from the IOL and all, like where was it placed? Because this sounded interesting to me. So
Yes, sir.
anyway, let's go ahead. Yeah.
Yes, sir. So refractive surgery can basically be qualified into three types of procedures, which are the corneal refractive procedures, lens-based procedures, and combined lens and corneal refractive procedures. So today, for the basis of this discussion, is going to be the keratorefractive surgeries. So keratorefractive surgeries in themselves are a whole umbrella term. They include addition of tissue, subtraction of tissue, relaxation of tissue, or the coagulation of tissue. And depending upon which layer of the cornea it affects, we describe it as superficial, intrastromal, and peripheral cornea. So for the sake of this discussion, we are going to discuss the subtraction of tissue. In superficial layer, we have PRK, LASIK, EpiLASIK, and Epi-Bowman keratectomy. In intrastromal, we have LASIK, femtolasic, and SMILE. So a bit of basic about laser vision correction in myopia and how we intend to shape the cornea in myopia. So in myopia, we want to flatten the central cornea and steepen the peripheral cornea. Similarly, in hyperopia, we want to create a steepening of the central cornea and flattening in the periphery. And in astigmatism, there is a steep meridian and a flat meridian. So the entire purpose of the laser vision correction in astigmatism is to create a resulting spherical optical zone. A bit about how the lasers interact with tissue. So once the laser falls onto the cornea, there are four possible outcomes. Either it can get reflected, it can get absorbed, it can get transmitted, or it can get scattered. For our discussion, the important two are absorption and transmission. Absorption of the laser rays occurs at a wavelength below 350 nanometer, which is done by the excimer laser. Transmission occurs between the wavelengths of 400 to 1600 nanometers. And examples of these lasers are argon and Nd:YAG. They pass through the cornea with minimal tissue interaction, so they can be used for PIs or PRPs or capsulotomies. Once the laser gets absorbed by the tissue, there are three kinds of effects which are produced onto the cornea, which is a thermal effect, a photochemical effect, and an ionizing effect. In thermal effect, we have photocoagulation, photodisruption, and photovaporization. In photochemical, we have photoradiation and photoablation. The two important interactions we need to know for our discussion are the photoablative and the photodisruptive. So the photoablative laser that we use commonly is the excimer laser, which is an argon fluoride laser. And electrical energy is basically used to stimulate argon to form a dimer with fluorine. This excited dimer breaks with the release of photon, and the wavelength of that photon is a 193 nanometer wavelength, which is in the UVC spectrum, which is not in the visible spectrum. This 193 nanometer wavelength ray gets absorbed by the cornea, and it breaks the carbon-carbon and carbon-nitrogen bonds of the corneal collagen, and hence a layer of tissue gets vaporized. Due to the high absorption in the cornea, there is a great degree of precision in the excimer laser due to less thermal spread, and it also causes minimal damage to adjacent tissues. Coming to the second type of laser that we use commonly, which is the photodisruptive laser, that is femtosecond laser, which is a solid state laser, the wavelength being 1063, 1053, 1063 nanometers. It is falling in the infrared division, and the duration of that laser, the pulse of that laser is in femtoseconds, which is 10 raised to minus 15. It basically causes laser induced optical breakdown. So there is a highly focused and a short duration laser pulse, which generates a very high intensity electrical field, which essentially transforms the tissue into plasma. This formed plasma expands rapidly and causes tissue separation. Plus, a very tiny quantity of corneal tissue is also vaporized. The main point being that there are cavitation bubbles which are formed, which get absorbed over time by the corneal pump mechanism, or they get dissipated once the flap is lifted. So coming to how the excimer laser has evolved over time. So first few generations of laser were broad beam, and we had only a fixed optical zone. Then came a setting to variate the optical zone, and we introduced multi-zone treatment. After that was the introduction of flying spot mechanism, flying spot laser beams instead of the broad beam. And also we introduced a built-in tracker. The newer generation of excimer lasers can also do customized wavefront guided or optimized treatment, which have a faster ablation rate and tracking. We can also have advanced ablation profiles, and the newer machines also have cyclotorsion control. In this example, what I'm trying to show is the image on the left shows the primitive broad beam laser. The disadvantage with broad beam laser was that there was a lack of predictability, and there was a lot of intraoperative fluctuation of laser beam energy, which essentially led to formation of central island formations of untreated areas. The latest machines work on these two principles. This is the scanning slit laser beam, and this is the flying spot laser beam. Coming to the advantages and the advantages of the newer generation excimer lasers, which being they have enhanced ergonomics, they have advanced ablation profiles, there is automated tracking, there is cyclotorsion compensation, which all leads to reduced treatment times. Conventional eye tracking in excimer lasers usually used to capture a rate of around 60 to 330 hertz, and their response time was 36 milliseconds. They only allowed adjustment of movements into X and Y axis. The newer generation of eye tracking, eye tracking in newer machines is based on the pupil or iris vessels or the conjunctival vessels. There are two types of eye tracking which we have now. One is active eye tracking, the other one is passive eye tracking. Active eye tracking resets the position of the laser beam with eye movements in order to ablate the desired area. Whereas the passive eye tracking involves stopping the delivery of the laser entirely if eye movements cross a certain threshold. The fixation of the eye may be maintained by the patient during surgery or by handheld fixation suction rings. A new machine, the Schwind Amaris 1050, has a few added advantages in eye tracking. It tracks the eye in 7 dimensions. It has latency-free tracking. It essentially calculates the corneal target position for the next 2 consecutive pulses, which allows the scanner to move to the predicted position of the laser before the next pulse is triggered. Cyclotorsion control in new machines. So there are two types of cyclotorsion control. One is static cyclotorsion, which occurs with movement when the patient is upright to supine movement. It has been noted that we do all the scans when the patient is in sitting position, that is when he is upright, and we do the treatment in supine position. So it has been noted that up to 2 to 4 degrees of cyclotorsion occurs when a patient moves from sitting position to supine movement. So cyclotorsion control compensates for that. Dynamic cyclotorsion occurs during ablation, which also gets compensated by the new machines. They have very fast acquisition speeds of 1050 hertz. Earlier, it was around 330 hertz. And the response time in comparison to 36 milliseconds is now only 3 milliseconds. With the sixth generation lasers, due to fast repetition rates, there is a huge reduction in treatment time. The older platforms had a lower frequency, hence they took around 7 to 10 seconds per diopter of ablation performed. In newer machines, the 500 Hz laser platforms take around 4 seconds per diopter of ablation for an optical zone of 6.5 mm. So there was introduction of a new treatment pattern as well. There are two types of treatment patterns which can be done. One is multi-zone technique and one is multi-pass technique. Multi-zone techniques involves dividing the treatment into multiple concentric ablations of varying diameters and depths in order to improve the ablation profile. Multi-pass technique, whereas, involves dividing the treatment into a series of successive treatments over a few seconds in order to avoid excessive increase in tissue temperature. In the current machine, both multi-zone and multi-pass techniques are used to achieve optimal smooth stromal surface and great outcomes. Coming to advantages of the latest scanning slit or flying spot technology, basically they lead to a smoother corneal surface, which leads to higher quality of vision and leads to a lesser chance of haze. With these two types of lasers, we can have larger diameters of ablation. And scanning slit and flying spot help us customize the treatment based on the topo value, Q value, or wavefront values. So the conventional ablation was performed based only on subjective and objective refraction. There was no wavefront data, no topo data, or any other data which was or Q value which was involved in the calculations. The treatment was based on only theoretical models and a Muller-Lin formula, which I'm going to describe later. So there were three fallacious assumptions which were made in the earlier conventional ablation profiles. The first one being that cornea is spherical, but as we know now that cornea is aspheric. It has a prolate shape. It is steeper in the center and flatter in the periphery. The second fallacious assumption was that optical zone was the same as ablation zone. And the third, that the rate of photoablation was uniform along the corneal surface. All these three factors led to various adverse effects with conventional ablation, which included significant glare, halos, and decreased contrast sensitivity. The Muller-Lin formula, on which conventional ablation was based, estimated the ablation depth in myopic corrections as thickness of the tissue ablated is equal to the diameter of optical zone in millimeters square into dioptric correction spherical equivalent upon 3. It essentially meant the removal of a convex concave lenticule with spherocylindrical surfaces. This table shows the latest excimer laser machines which are available to us: the Alcon Wavelight X500, Zeiss Mel 90, Schwind Amaris 1050, Nidec Navex Quest, and Bosch& Lomb Technolas Teneo. The important point to note here is that the spot size is very low in all of them. They use the latest flying spot or a slit scanning technique. We can do customization of the treatment in all of them. They have multi-dimensional eye tracking, which has a very high speed and a very quick response time. Pupil and limbus tracking is available in all of them. One advantage with Alcon Wavelight X500 and Schwind Amaris is that there is online real-time pachymetry available on these platforms, which other platforms don't.
So Pranav, which of these machines has dynamic tracking?
So dynamic tracking is in Schwind and Alcon Wavelight.
And what is tracking? What is it tracking dynamically?
So it's tracking the pupil movements of the pupil.
So see, the pupil tracking is dynamic in almost all machines, almost. I mean, all the current machines will have dynamic pupil tracking. But as you mentioned about cyclotorsion control, so but is there any of the machines which has active cyclotorsion tracking
Active cyclotorsion
and
tracking.
active iris tracking? I mean, the iris landmarks or the limbus landmarks, because that would basically help us understand that which machine may be actually doing a better job with doing dynamic cyclotorsion, because the cyclotortion is dynamic. Of
Yes, sir.
course, pupil tracking is required because you want to center the ablation. Okay.
Yes,
So
sir.
that will be very important when you're trying to do a spherical ablation. But when you're doing astigmatism or topoguided treatments, then it becomes imperative to have cyclotorsion, active cyclotortion tracking as well. Right. So
Yes, sir.
I was just keen to understand that which of these machines, as you mentioned, that some of the new machines have an active cyclotortion tracking. So I don't know which one has it. I don't think
Sir, I will
EX500
find
has
out
that.
and I will find out and put it, sir. Put it up, sir.
Sure. Sure. So basically, what I understand is that our machine has the EX500 will do when we do that registration, which we do before we do all the topo guided treatments and all for cyclotorsion, it is a passive thing, which means that it will take a registration and then it will decide, but it cannot actively monitor the cyclotortion of the eye, and it cannot compensate for it. It will just do it one time because it assumes that once it has done that, the patient cyclotortion will not change, right? And we will then keep ablating accordingly. Because I feel, because it's doing cyclotortion tracking or doing iris registration tracking uh, requires a very, very efficient, I mean, tracking system, which I don't know whether any of the current machines are capable of yet. Maybe with new technology, because the CREX 500 is at least 8 years old now, maybe 9 years old, right? So maybe one of the newer machines like the Amaris, which if they have a newer model, or the Teneo, they may be having cyclotortion, dynamic cyclotortion. So it will be worth knowing. Later on, you can share it on the group. Okay?
Yes, sir. Yes, sir.
Great. Let's go ahead. Yeah.
Yes, sir. So apart from the conventional ablation, which induced a lot of glare, halos, and a whole lot of problems, uh, scientists developed 3, 4 more additional patterns of treatment, which were based on various diagnostic equipments. First came the wavefront optimized ablation, then wavefront guided, and then topo guided. So in wavefront optimized ablation, what they do is that they simply prevent the induction of new higher order aberrations. They do not treat the pre-existing higher order aberrations, but the treatment is such that new higher order aberrations are not induced. Whereas wavefront guided ablation and topo guided ablation treat pre-existing low order as well as high order aberrations, as well as minimizing induction of new higher order aberrations. So in wavefront optimized ablation, there is no wavefront data required, but the ablation profile planning is based mostly on the manifest refraction. Wavefront guided ablation depends on the ocular wavefront data and manifest refraction. This ocular wavefront data is important to note that it is the wavefront data of the entire ocular system and the entire eye. Whereas in topo guided ablation, the ablation profile is essentially based only on the corneal wavefront data. Wavefront data acquired in wavefront guided ablation is pupil centered, and centering the data on pupil is susceptible to errors due to pupil centroid shift, which occurs with change in illumination and also accommodation. Whereas topo guided ablation requires wavefront data which is based on the corneal vertex. Hence, it is not susceptible to errors due to pupil centroid shift. Wavefront guided ablation, therefore, is suited mostly for patients with a very high preoperative higher order aberrations, which is more than 0.4 microns, and moderate refractive errors. An essential point to note is that in wavefront guided ablation, reliable ocular wavefront data should be acquired and the cornea should be fairly regular. Whereas topo guided ablation is suited for patients with reliable topo scans and a significant corneal higher order aberrations or even virgin eyes. The advantage of wavefront guided ablation includes that it takes into account the entire ocular aberration profile. However, there are a few limitations of wavefront guided ablation, topo guided ablation, and wavefront optimized ablation. In wavefront optimized ablation, we do not correct the pre-existing higher order aberrations, and more amount of tissue is ablated in the periphery in wavefront optimized ablation. In wavefront guided ablation, the treatment relies essentially on very accurate acquisition of wavefront data, and expensive aberrometers are required for the same. The wavefront data which we acquire by aberrometers is static, whereas the patient's actual wavefront is dynamic. Getting good quality aberrometry scans is not feasible in highly aberrated corneas, so wavefront guided ablation is not the ideal choice in highly aberrated corneas. The treatment accuracy, like I mentioned before, is also affected by the pupil centroid shift, lenticular accommodation, and intraoperative cyclorotation. That is where the role of topo guided ablation comes in. However, it also has its limitations because the treatment in topo guided ablation relies on repeatable and accurate and reliable topo scans, and it does not take into account the internal aberrations of the eye.
So, Pranav, what is the disadvantage of wavefront guided treatment? One of the main disadvantages. You've told the limitations, but I'm asking about the disadvantage.
Sir, the wavefront data that we acquire is not entirely accurate because we are compensating for the lenticular and the internal astigmatism of the eye as well, which is dynamic, as I mentioned. So you cannot really always, because the level of illumination in our operating, I mean, when the patient is looking at the light, the level of illumination is changing. So that also induces a change in the wavefront profile of the entire eye if you are considering. So that can also cause an error, sir.
How is aberrometry done? How do we do aberrometry when we are trying to do wavefront customized treatments, like wavefront guided treatments? How do we do the aberrometry actually?
I'm not sure, sir.
I mean, what should we do before we start doing aberrometry for a patient if we are trying to do a wavefront guided treatment
Sir,
planning?
cycloplegic aberrometry, sir.
Right. So what you're essentially doing is you need to do it on a bigger pupil size because frankly, the advantage of wavefront guided treatments is only when you are correcting aberrations which are from a bigger pupil size. You know, in a small pupil size, if you try to correct it, the aberrations will be very little. There'll be hardly any aberrations because in a constricted pupil, you know, in the central, the area will be. So typically when we used to do abrometry, we used to do a lot of these wavefront customized treatments in the early 2000s, like 2005 and 6. I remember we used to do it. We had an abrometer, and there are two kinds of abrometers you must be knowing already, like Schoening type and the Hartmann-Shack
Yes, sir.
type. And so, right, so we used to do abrometry, and then after that, you know, we had to see the data and try to decide whether this is going to help the patient or not. But typically, the abrometry was done in a dilated pupil, and then we would try to correct. So, frankly, the lenticular aberrations would change completely in a cycloplegic state, whereas, and as you said, they're dynamic, right? So all the aberrations are dynamic. So that's why the predictive, and then you're trying to correct maybe internal aberrations on the cornea, which is not a great thing. You know, you're trying to superimpose corrective treatments on the cornea, which aberrations may exist. And as you have seen recently, you know, on the eye trace, sometimes the internal aberrations may be crazy. I mean, you know, now we can segregate them between the cornea and the thing. At that time, we didn't have the technology to segregate them. So, you know, otherwise at that time, had we known this, we would have separated out those patients who had internal aberrations which were very bad because then you were trying to correct it on the cornea, right? So that is why it
Yes, sir.
evolved into eventually topo-guided treatments because there's no point treating the internal aberrations because they will constantly change. And eventually, when you do a cataract surgery at some point, then it will go haywire. Right, all those will be gone, and you would have tried to correct them on the cornea, and they will all become vision will become worse.
Yes, sir.
So that is why it evolved into a topo-guided treatment for cornea. Okay.
Okay,
So
sir.
anyway, let's go ahead. Yeah.
So a few
Anybody else has
commercially,
any questions over here? I mean, Dr. Ruchika, any comments, and anybody else has any questions so far, like on what we covered? Otherwise, we'll forget what we've covered, and then you know there will be no discussion.
No, I think so. He's covering it quite
He's
well,
covered
actually.
everything. Yes. So I want to ask Shritu something. That did you understand what is wavefront optimized and how it is different from you know the previous generation of treatments that we were doing? What is wavefront optimized?
Yes, sir. Hello, sir. Am I audible?
Yeah.
Yes, sir. Wavefront optimized, sir. Basic difference of wavefront optimized and sir, I understood, sir.
बताओ क्या है ना? That's what I wanted to know.
Sir, wavefront optimized basically corrects the lower order aberrations. It does not correct the higher order aberrations. While the
That's okay,
wavefront,
but even the standard treatment was correcting the lower order aberrations only, right? I mean, what changed when wavefront optimized came up? That's what I wanted to know. What changed with our treatments once wavefront optimized came in from the previous generation of treatments that we were doing? How was it better and why was it better?
sir, because it offered a more customized treatment
In what
uh,
way?
uh, from the previous program, sir. Because it improves the quality of vision, sir. It reduced glare and halos.
Right, but how? That's what you're right. How did it reduce the glare and halos? What changed with wavefront optimized?
Sir, what changed from the previous ones? No?
I mean, you know, see, wavefront optimized came up somewhere in 2002 or something.
Haji, sir.
For the first time. Before that, we were still doing lasers, right? I mean, we were doing LASIK before that also. There was a Xioptics was available and Bosch and Lomb platform, and there were a couple of Nidec was there, broad beam laser. And we just discussed about the shortcomings with that. And, you know, the things changed when wavefront optimized came up. So what changed? I mean, what was the difference in the ablation profile of the cornea on which was being done with the wavefront optimized treatments? How were they different? Why did the glare and halos become less?
Um, sir, because sir, because it used to treat the lower order aberrations as well as the imperfections that was there, sir. Like
No, 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 no.
Sir,
Maybe.
may I?
Yes, try. Pranav, since you've read it recently, you might be knowing it. Yes.
Sir, it also wavefront optimized included creation also of a transition zone and treatment in the mid periphery as well, so that there was no sharp cutoff between the ablated and a non-ablated zone.
Hmm. You're right to an extent. There is a transition zone which was created. But what was the true optical zone became much bigger with wavefront optimized as compared to what we were getting. See, we used to use 6 optical zones before also. And even now we were using 6 zones. So obviously we did get a transition zone. So that's why the ablation zone became much bigger. Like for a 6 optical zone, you were treating actually 8 or 8.5 millimeters, right? But what were we doing in that peripheral area? What was like, there was one transition zone, of course, but what else?
Mm. I'm not sure, sir. I will find it out, sir.
You just said that, in the mid periphery, we were doing something more, right?
Yes, we were ablating.
The sun's at 12 noon, you will get a round, Can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Hello? Right. So imagine that you're sitting on a hilltop, the sun is there, you will get the full force of the sun. But if as you start going down on the sides, that same thing will start becoming that round, instead of a round spot, it will start becoming oblique. Okay. So the laser energy which was delivered in the peripheral, mid periphery of the cornea used to be, there were two things happening. One was that the spot was no longer the same spot, round spot, which was, falling on the center. So the energy was not the same. It was less and it was spread out over a bigger area. Also, the reflectance was there. So when you were hitting it straight from top, there was almost very little reflectance. So the effect was full. Whereas in the peripheral cornea, it used to get reflected off. Some of the beams were reflected off because it was falling obliquely. All right. So the effect of that laser spots in the periphery was much smaller than that was in the center. So the treatment was used to be less in the periphery as compared to the center. So you used to get good quality vision in the central zone. So the effective optical zone was much smaller, maybe just about 3 to 4 millimeters. And as we went further into the periphery, the treatment effect was much less. So what these new lasers started doing, what was optimized was that they started firing many more shots in the periphery as they were firing in the center to achieve the same effect which was being achieved in the center. So effectively what happened was that our effective optical zones went from just about 3 to 4 millimeters to a true optical zone of almost 6 and then a transition zone as well. All right. So you started getting much better quality of vision and less problems with the pupil. See, we used to think that we are doing a 6 zone, but with a pupil of say 4 we were actually getting only a 3 or 4 So people used to get ghosting and halos and everything. But now with the same pupil size, because now our optical zone went from just about effective optical zone went from just 3 to 4 millimeters to almost 6 or 6.5 millimeters. So those problems which were there in the initial days with the glare and halos, they kind of went away because you're actually getting a true optical zone which is much bigger and a transition zone to go with it. So it was blended. So that is the thing I was trying to put across, because we used to read this a lot when we started doing wavefront optimized in 2002 and so. But now most people would not know about it because we take it for granted. Okay. So anyway, let's go ahead.
Sure, sir. So these are the few platforms commercially available right now. Wavefront guided ablation platforms include the custom cornea LASIK, LiDAR vision by Alcon, Technola's personalized vision corrections dioptic system by Bosch and Lomb, custom view LASIK's Vizix Star by AMO, Wavelight Allegretto wave excimer laser, advanced custom view LASIK Vizix Star by AMO, and topo guided ablation is only available in two platforms, which is the Wavelight Allegretto Wave IQ excimer system and Final Fit custom ablation system.
No, so you're mistaken here. Topo Guided is available on the MEL 90 also. It is also available on the NIDEC platform, as you said, and it is also available on the Schwinn platform and the EX500. So at least four I know, but maybe there are more also.
Okay.
Maybe I think even Bosch and Tinio now has an option for Topo Guided. I'm not sure.
Okay, sir. I'll correct that, sir.
Is Topo Guided treatment FDA approved?
Topo guided, I don't know, sir.
So US FDA actually was doing trials for Topo Guided treatments when they found that they insisted on doing trials on virgin eyes. So when they started doing on virgin eyes, virgin corneas, they wanted to prove that at least on virgin corneas it is as safe as the wavefront optimized. That was what FDA wanted. That is why the initial trials were done, and they found that they actually improved the results on virgin eyes as compared to wavefront optimized, which was a surprise for them. They were only doing a kind of a trial to see whether it was as good as wavefront optimized and no other complications were there. So that is how this Contura was born basically. Otherwise, topo-guided treatments had been, we had availability of topo-guided treatments. Contura was born when the US FDA trial showed that, there could be an advantage in treating virgin corneas with topo-guided treatments as, not only like diseased corneas or unhealthy corneas with aberrations, right? So I don't think topo-guided treatment is still FDA approved on non-virgin eyes. They still haven't approved it, but they did approve topo-guided treatment in part on the healthy normal corneas. So that is called Contura. Okay.
Okay, sir. Okay, sir. So coming to another modality of treatment which is available on the newer excimer lasers is the Q value based treatment. So a basic anatomy tells us that normal cornea is prolate and the Q value is between minus zero point 0.2 to minus zero point 0.3. Essentially, it should be less than, it should be between 0 and minus 1. And the normal cornea has a slightly positive spherical aberration of zero point 0.2 microns. The wavefront optimized or wavefront guided treatments include aspheric treatment, but we cannot control the amount of intended asphericity. So any treatment induces an oblate change in the cornea, which causes more spherical aberrations. The Q value based treatment involves setting up of intended post-operative asphericity. Q value based treatment essentially does not need any topo maps or wavefront profile. The mean asphericity is modified by symmetrically adjusting the number of mid-peripheral laser pulses, and a target value of 0.4 to 0.6 results in minimal spherical aberrations. Custom Q is the aspheric ablation profile available on Wavelight X500 platform. Another platform which
So
we,
if you wanted to do, if you wanted to do custom Q,
yes sir.
Pranav, if you wanted to do custom Q on our machine, the EX500, and maybe Shitu can answer this also, how would you which treatment modality would you use?
FCAT.
FCAT, sir.
Right. And on FCAT, how do you feed the existing Q value? Yeah. What is the full form of FCAT? So full form is fine customized aspheric treatment. All right, fine, FINE. Huh? So
Okay.
also because it allows customization of many things, including optical zones in steps of 0.1 and lots of other things. So obviously you can customize the Q value, the target Q value can be fed in it. But how will you feed the existing Q value? Because you can only change it when you know what is the existing Q value.
So
Where
Q
do you get
value
it
will
from?
get from Pentacam, sir.
Okay, so how will you
Quality.
get it? Which map?
Sir, it's there in
Hmm?
the leftmost part below the quality scan QS.
And
We check if it is okay or not, and below that only the Q value is given
yes.
in the extreme left and the extreme
So are
right.
you sure of this on that map? QS is Q value also given over there? I'm not.
Yes, a Q value is there in the pentagram map, sir.
Okay, and Q value is measured at what degrees? So Q value will change at different degrees from the center. Like at 30 degrees, it will be something else. At 20 degrees, it will be something else. Which one are you going to use? Did you know that Q value will change as you move out from the center to the periphery of the cornea?
So
Yes,
Right,
sir.
because
Yes, sir.
it measures the asphericity
asphericity
of
of
the
the
cornea, right?
Asphericity.
cornea.
Yes,
So
sir.
which
Yes, sir.
one are you going to use? Because Pentacam will give you at several points. Which one are you planning to use?
Hmm.
So this is homework for you.
Yes,
Okay.
sir. Yes, sir. Yes, sir.
Okay. And Shritu, you have done a few FCAT treatments, right, with Dr. Ruchika?
Yes, sir. Mm.
How did you feed the Q value there? From where did you feed it? Did you try to understand that?
Sir, we take the scans before each surgery, sir.
Which
The
scans?
patient scan, sir.
Which, मतलब on which machine?
Sir, there only in the LASIK center.
So what is that machine?
Sir, I'm just not getting the name. I know the name, sir.
There's
Uh,
the topolizer.
Doppler.
Right. तो उसको वो तो
क्यू वैल्यू में
स्कैन्स तो लेते ही हैं, वो तो
हाँ
रोज ही
जी
लेते
सर
हैं सारे पेशेंट्स के, है ना?
हाँ
कॉन्ट्यूरा के लिए भी लेते हैं, वैसे भी लेते हैं, बट उनमें से आपने देखा था कि क्यू वैल्यू हमने कब फीड करी और कैसे फीड करी, कहाँ फीड करी, और टारगेट क्यू वैल्यू हमने कितनी डाली? डिड यू पे अटेंशन टू दैट एवर ऑन एफ
सर
कैट?
sir we feed all the scans in the machine sir and then we
ओके,
select
नहीं वो तो ठीक है, मैप तो सिलेक्ट कर लिया, बट आपने ओरिजिनल क्यू वैल्यू और टारगेट क्यू वैल्यू पे कभी ध्यान दिया?
हम्म, नहीं सर
Because that is one of the customizations which is possible on the
हाँ जी
FCAT,
सर
na? So I think, so you try to understand, I mean, try to find this out in the next LASIK session to see that what will be how we feed the original Q value, like the existing Q value of the eye, and how we calculate the intended Q value and how we can change it and how we can play with it. ठीक है?
ठीक है सर
ठीक है, चलो जी, let's go ahead.
Another platform that we have is ray tracing based ablation, which is not in common use. So basically, it considers a wide variety of parameters, including the lower order aberrations, ocular wavefront as assessed by an aberrometer, corneal higher order aberrations generated from topo and tomo maps, biometric data such as the axial length, keratometry, pupil diameter, corneal thickness, and retinal thickness. So in ray tracing, what is unique is uh, there is an individualized eye model which is created on the basis of all this data. All the previous treatment patterns were based on the Gulfstrand model of the eye, but ray tracing based ablation generates an individualized eye model. It also takes into account multiple lens nature of the eye and the intraocular structures and the anticipated biomechanical response of the cornea to the ablation and the impact of wound healing. Coming to microkeratomes. So traditional microkeratomes consisted of a motorized or a manually driven blade that cuts the flap at a fixed rate, typically fixed thickness around typically 130 to 180 microns. The limitations being that there are a lot of buttonholes, incomplete flaps if they are not used with precision by experienced surgeons. However, the modern subbowman keratomylosis microkeratome is designed to consistently create thinner and more precise flaps with a very tight standard deviation of around 100 microns. This is achieved through a different cutting technique where the blade oscillates at a very high speed, creating a uniform pass over the corneal surface to create a smoother and almost planar flap similar to the flap which is created by the femtosecond laser. There are a few notable advantages of the SPK keratome, which is enhanced safety, greater precision, with flap thickness possible as low as 100 microns and predictable outcome and lesser risk of complications, which leads to faster healing and superior visual outcomes. In this image, we can see that the one on the left is made by a newer generation microkeratome, and this one is made by the femtosecond laser.
7-8 years without gloves. Okay, and then second thing is that we found that the हैंसरटोम में ना जो gears होती थी और जो उसमें जब माइक्रोकेराटोम चलता था तो उनको करने के लिए ना उसमें an oil was used to keep the gears moving. All right. So they found that that oil which was used for the microkeratome gears would lead to DLK also. So then they had to find a way of eliminating that also. So once all these things were eliminated, then the incidence of DLK went down drastically. Okay.
Yes, sir.
चलो जी, so आगे चलते हैं. There's a lot of history in microkeratomes actually, which we should ideally know about. And I mean, just for the sake of knowing how refractive surgery evolved, not that it's very relevant today, but it's good to know. So let's go ahead. Okay, femtosecond laser.
Yes, sir. So, sir, this link might expire in a few minutes, so I'll share one more link, sir.
नहीं, फिर बाकी हम बाद में कभी कंटिन्यू करेंगे. अभी जितना हो जाएगा कर लेते हैं. चलो.
Okay, sir. So, femtosecond laser, there are two types of femtosecond lasers available. One is a low frequency, high energy, and the other is high frequency, low energy. So, the low frequency, high energy platforms include Intralaser by AMO, Femtech by Technolas, Visumax by Carl Zeiss, and Wavelight by Alcon. The centration in these is automatic. There is extensive flap customization available in these, and there is no masking agent required. Whereas the high frequency, low energy platforms, which is the Femto LDV by Zemer, there is manual centration in that, and only a limited amount of flap customization is available, and a masking agent is required to use these machines. The first generation femtosecond lasers had a very low repetition frequency, which was limited to 2 kilohertz. So in order to perform an acceptable cut, a fairly high energy levels were required with significant inflammation post-operatively. So the newer machines with higher operational frequencies make it possible to bring the spots closer together, and this causes a consequent improvement in the quality of the interface. So in the first image, we can see the high energy and low frequency laser, how it works, that there is a lot of spot separation in between, whereas the low energy and high frequency platforms have a very little spot separation between them. So these are the femtosecond machine lasers available. Intralaser by Abbott, Technolas by Technolas Perfect Vision, Femto LDV by Zemer, Visumax by Carl Zeiss, and Wavelight FS200 by Alcon. As you can see, the frequencies are very high, but Femto LDV Zemer has a very high frequency. The pulse duration is also low. The energy used is low, but it is even lower in the Femto LDV because the frequency is higher. Time for flap creation is almost around somewhere around 15 to 18 seconds. Some of them use a spiral system, some of them use a raster system or a segmental system. There is a difference in the applanation surface in most of them. The Intralaser has a planar applanation surface. Wavelight FS Alcon has modified planar, whereas the Technolas and Visumax have a curved applanation surface. So just a general comparison between the microkeratome and femtosecond based corneal flaps. The architecture in the microkeratome one is a meniscus shape, which is thinner in the center and thicker in the periphery, whereas the femtosecond laser is planar. However, the new SBK keratome is also capable of producing a planar flap. The flap in microkeratomes is less customizable, and the hinge position is based on the position of the microkeratome, whereas the femtosecond laser allows us to fully customize the size, shape, location, and depth of the corneal cuts. Microkeratomes are less predictable, and there is a wide variation in the flap thickness and diameter. It has a uneven interface, whereas the femtosecond laser has a better, smoother interface, which leads to better flap adhesion. The IOP rise in microkeratomes is significantly higher at around 160 to 300 mmHg, depending on which microkeratome is used. Whereas in femtosecond laser, the IOP rise is somewhere around 50 to 100 mmHg, depending on the platform that is used. So in general, the microkeratome gives us a greater induction of higher order aberrations and worse contrast sensitivity, whereas the femtosecond laser gives us a better visual quality. Coming to a few advantages of femto LASIK over microkeratome LASIK is that the flap can be customized. That is the thickness, diameter, hinge location, and hinge angle. We have precise depth control and precise flap dimension and locations. Flap can be centered intraoperatively in femto LASIK, and the flap thickness is not affected by the pre-op corneal curvature, thickness, or translational speed or IOP. The flaps are usually clear without debris, which leads to a decreased risk of DLK and infection. The nature of the flap itself is such that it eliminates epithelial ingrowth and decreases all the complications associated with microkeratome like free cap and buttonhole. Also, a huge advantage with using the femto to create the flap is the ability to retreat immediately if incomplete femto destruction occurs. A few disadvantages of femto LASIK over microkeratome LASIK include that in femto LASIK there is a longer suction time, and the OBL, that is the opaque bubble layer, can interfere with the excimer ablation. There is increased treatment time, and there is transient light sensitivity and an overall increase in treatment time. Coming to the basics of the surgeries that we perform, it can be beautifully seen by this diagram. In LASIK, we create a flap which either by the femtosecond laser or the microkeratome, we lift up the flap, excimer laser is thrown onto the anterior surface of cornea, and the flap is repositioned. There is no need for a bandage contact lens. In PRK, that is photorefractive keratectomy, the epithelium is removed by one of many ways. The excimer laser is applied and a bandage contact lens is put. In LASIK, which is the laser assisted subepithelial keratomylosis, we first do a partial trephination of the cornea, and alcohol is applied onto the anterior surface of cornea to loosen up the epithelium, and an epithelial flap is made. The excimer laser is fired, the epithelial flap is repositioned, and a bandage contact lens is put. In epi-LASIK, also known as epipolis LASIK, an epikeratome is used to make an epithelial flap, after which the excimer laser is applied, the flap is repositioned, and a bandage contact lens is put. So basically in surface surgery, the Bowman's layer is exposed for excimer ablation with or without epithelial debridement. So the point to note here is that epithelium ablates faster and at an irregular rate than the corneal stroma. So in PRK, the epithelium can be debrided using either a sharp blade, a blunt spatula, a rotary corneal brush, 20% alcohol for 10 to 45 seconds, absolute alcohol, microkeratome with an epilasic blade, or the latest thing that we use is a trans PRK, which is trans epithelial ablation from the excimer laser itself. So the ablation is stopped once the fluorescent pattern changes to dark pattern, which indicates that the epithelium has been ablated. Coming to basics of relax flex, refractive lenticule extraction. Sir, am I audible?
Yes.
Yes, you are.
Okay, sorry. So refractive lenticule extraction, femtosecond laser lenticule extraction. So in this, just like femtoLASIK, we create a flap under which with the femtolaser we have created an intrastromal lenticule. After lifting of the flap, the lenticule is lifted off the cornea. In SMILE, a similar thing is done. An intrastromal lenticule is prepared, which is extracted through a very small keyhole incision in the cornea. There is something also called as pseudo SMILE, which entails the creation of an intrastromal lenticule, which is similar to flex. The hinge is shifted temporally, and during the lenticule dissection and extraction, the flap is not lifted. So in this image, we can see the white line marks the border of the femtosecond laser application, and the flap is lifted off, under which the lenticule is there, which is then extracted and the flap is reposited. In pseudo SMILE, the yellow dotted line indicates the demarcation of the femtolaser cuts. However, the entire flap is not lifted, but a 5 to 6 mm small incision is made through which the lenticule is extracted. In SMILE, as we know, only a small incision is made from 2 mm to 4 mm for extraction of the lenticule. So there are a few advantages of relax over femtoLASIK, which being that only a single laser is required. So economically it might be more feasible. The refractive predictability is very high because the lenticule is cut rather than ablating the cornea which with excimer laser, because the excimer laser abrasion rate also depends on the corneal hydration status and the environmental factors like the humidity of the room and also the time we take for delivering the excimer laser to the cornea. The amount of tissue treatment required per diopter is lesser in SMILE. The total energy used is lower than LASIK, and it is a faster treatment because we don't have to switch between two lasers. There are no flap related complications. There is definitely faster healing, less patient discomfort, and less dry eye. Coming to recent advances, I'll try to cover this quickly, sir. I'll be discussing VisuMax 800, small incision or smooth incision lenticule keratomiliosis, which is known as silk, corneal lenticule extraction for advanced refractive correction, which is clear, smart sight, or laser induced refractive index change. So in VisuMax 800, the frequency is now higher, which is 2 megahertz. Cutting speeds are faster, so a lenticule can be created in less than 10 seconds. There is a very short suction time, therefore reduces the probability of potential suction loss. There is a new system called CentraLine, which is a computer controlled function for easy centration of the eye during the surgery, as well as Oculine system for easy cyclotorsion alignment. A new technology also introduced in somewhere around October, November 2023, which is when it got FDA approval, is smooth incision lenticule keratomiliosis. Not FDA approval, CE approval. It uses a new femtosecond laser platform known as ELITA. It allows for uh, adjustment for centration over the entrance pupil as well as cyclotorsion control with a very high speed laser and low energy setting with a very small focus size. Basically what it gives is overlapping spots which allows for very minimal dissection of the lenticule, which enables nearly dissection free removal of the lenticule. Another important difference in silk versus SMILE is that in silk we have a biconvex lenticule, which helps that the corneal microfolding is minimized or eliminated following lenticule removal. In corneal lenticule extraction for advanced refractive correction, clear by Zemer LDV Z8 laser. Like I mentioned before, it has a low energy and high frequency laser, and it also offers options of recentering the treatment area after performing the docking, which is not possible with the current VisuMax laser system. It also offers cyclotorsion control without having to release the suction, and it also has an intraoperative inbuilt OCT. Smart Sight is a new technology introduced by Schwind Atos FS. Atos offers eye tracking. It also offers pupil recognition and cyclotorsion compensation to allow precise centering with a high repetition rate of 4 megahertz. And the energy per pulse is lower than with SMILE but higher than in clear. Coming to the last new advance, which is the laser induced refractive index change, which is introduced by Clario Vision. It is a 405 nanometer laser. There is no ablation, epithelium debridement, or flap cutting in this surgery, and this does not require any epithelial debridement. It uses very, very low pulse energies to essentially modify the tissue's refractive index. The energy which is used is about 100 to 1000 dose of which is used to create a femtosecond laser flap. Another application of Lyric is that it can be done to modify the IOLs as well. It uses low energy femtosecond laser to hydrolyze the IOL material and to change its refractive index. And these are my references, sir. And that was my presentation, sir.
Good, good, good. Very comprehensive and nicely done. And yes, there is a lot of excitement about all the lenticle extraction technologies today. And a lot of new things are coming up. So it'll be interesting to see how they evolve. But you have missed out on one thing which is also coming up now and which will be commercially available very soon. And that is from Alcon on the Wavelight platform. They're introducing the ray tracing treatment, which you spoke about. Are you aware of the name of that treatment?
No, sir, I'm not.
So it is now available commercially, almost ready now, and it should be seen soon. And it promises to be, a step ahead. It'll come with a new device for diagnostic device as well, which will be from Oculus, which will basically incorporate a pentacam with an optical biometer and a couple of other things packaged into one. And using that, we will be able to make a treatment plan for ray tracing treatments on the Wavelight platform. So that should come up before the end of this year.
Okay, sir.
I'm forgetting the name, but let me just check if I can find it. The Alcon ray tracing treatment is the name I'm forgetting. I knew it, just forgetting it. Mm, okay, I'm forgetting the name. I don't know. We'll find it tomorrow. I'm
Sir, I'll
forgetting the
find it
exact
out,
name.
sir. Yes, sir.
Mm, so it's called. Let's see. I was trying to find the name. I can't find it right now. Anyway, so that seems to be very interesting. The new evolution in examer technology, basically, right? Dr. Ruchika, anything that you felt that he missed out on?
No, sir. And actually, even I can't. I mean, all these NN meetings keep talking about the ray tracing platform. I'm forgetting the name myself.
Yeah, I'm forgetting. I don't know why I forgot. So it's the new exciting thing, and all the research has been done in Australia by this Indian guy. I'm forgetting his name also. And Ambati, is it Ambati? I'm not sure. That guy's name. Anyway, so also, I think, on the femtosecond flaps, you did miss out on a couple of things. You can, alter the side cut also of the flap. And therefore, the risk of flap slippage is much less with femtosecond flaps. And also that you can customize the side cut. They even had the side cut where you could actually, make it instead of 90 degrees, you can make it instead of acute, you can make it obtuse angled so that, it kind of fits, but it never became popular. And femtosecond laser also has applications for corneal surgery. For example, for intrastromal ring segments, it can create channels. And also for a lot of corneal surgeries, like for DALC and all, they can use that for, creating the donor and the recipient things. They have cornea modules on Visumax and Intralaser and all of these machines as well. And
Yes, sir.
even for camera inlay, you have for camera inlay, corneal inlays, you have another software which can be used for creating that pocket with the. So in femtosecond laser can be used for many applications. And so like a lot of good things. I mean, you did very comprehensive class actually, and it was very nice. So any other inputs from anybody else would be welcome.
Sir, class is almost about to end. I mean, the meeting time.
Okay, we'll wind up. I mean, you did very well. There's also this smart surf which you missed out on. That's also a new development from basically